Hey everyone, my name is Sammy Simpson, and today I would like to talk to you about the theory of acute pain management. The acute pain management theory is a middle-range theory with a physiological focus on pain and its balance between analgesia and side effects. The theory was developed by Marion Good and Shirley Moore in 1996. One of the theorists for this theory of acute pain management is Dr. Marion Good. She is currently an associate professor at the Francis Payne Bolton School of Nursing. She received both her doctorate and bachelor's degree in nursing from Case Western Reserve University. She then received her master's degree from Wayne State University in 1981. Her areas of interest include complementary medicine for pain and stress, acute pain, and stress and immunity. The second theorist is Dr. Shirley M. Moore. She received her bachelor's in science of nursing at Kent State University. She then went on and received her master's degree and PhD in nursing at Case Western Reserve University. Her, along with Dr. Good, are both associate professors. Dr. Shirley Moore is associate professor and associate dean of research at the Francis Payne Bolton School of Nursing in Cleveland, Ohio. At the time that Dr. Good and Dr. Moore were developing the theory of acute pain management, there were several descriptive theories of pain available, such as the specificity of pain, pattern of pain, and the gait control theory. These descriptions of pain existed at this time to explain how pain is perceived in the body, but how practitioners could actually relieve acute pain did not exist. Dr. Moore and Dr. Good thought that a prescriptive theory needed to be made that considered factors such as the patient, the nurse, and medical and nursing techniques and interventions. The overall purpose of creating this theory was to fill a knowledge gap. The overall purpose of the actual theory is to create a balance between analgesia and side effects in relieving acute pain. The theorists realized that pain is a complex phenomenon that takes many different concepts to create a balance between analgesia and side effects to create pain relief in moderate to severe pain. This theory has three major concepts. The first concept is multi-modal interventions, which incorporates the use of potent pain medication with adjunctive pharmacological and non-pharmacological measures to achieve good pain control with minimal negative side effects. The second major concept is attentive care, which incorporates frequent and regular assessments of both pain and pharmacological-related side effects, along with the intervention and reassessment designed to maximize pain control while minimizing negative side effects. The third major concept is patient participation, which provides patient teaching and encourages patients' goal setting for acute pain management and control of possible side effects. This is a model of how each concept comes together to create pain management, with a balance between analgesia and side effects. The first concept of multi-modal interventions can be broken down into three different areas. The first is potent pain medication. An example of this would be morphine, fentanyl, or Dilaudid. With a potent pain medication, you can add pharmacological adjuncts such as NSAIDs or acetaminophen. With the opioids and non-opioid medications, the nurse can then add a non-pharmacological adjunct, such as music therapy, relaxation therapy, or guided imagery. When you put all three of these things together, under the multi-model intervention, you have pain management and a balance between analgesia and side effects. The second concept of attentive care contains a regular assessment of both pain and side effects. To assess pain, the nurse would have the patient rate their pain using a rating scale, and they could also assess subjective and objective data for side effects of the opioid pain medications. The nurse would then identify what pain intensity and side effects that are unacceptable to the patient and the nurse. The nurse would then take all of these assessment findings and immediately intervene to decrease the patient's pain. The nurse would then use their multi-model interventions, such as opioids, pharmacological or non-pharmacological adjuncts, to treat the pain or side effect. After this is done, and some time has passed, the nurse would then reassess the patient's pain and or side effects and possibly then re-intervene if their first intervention was not acceptable. All three of these concepts under attentive care lead to pain management and a balance between analgesia and side effects. The third major concept is patient participation, and the theorists have broken this down into two propositions that are used together. Patient teaching is when the nurse encourages the patient to report pain, and does patient teaching on prevention of pain, inactivity, the use of complementary therapies, and expectations. The nurse with the patient then develop a mutual goal. These goals are mutually agreed upon, safe, and realistic for the relief of pain and side effects. The theorists propose that when the nurse uses each of these concepts together, there is decreased pain and a balance between analgesia and side effects. There are several relationships between each concept in this theory. Each concept is a different intervention, but when each intervention is used together, it creates the best pain control with the least amount of side effects. The use of analgesics, non-pharmacological interventions, nursing care, and patient participation all create a relationship with the one goal of pain relief. When using these things together, the nurse uses a holistic approach that creates a balance between pain relief and side effects. There are 5 basic assumptions found in this theory. The first is that there is a collaboration between the nurse and physician to effectively manage the acute pain. The theorists assume that the nurse and physician are working together to manage the patient's pain. The second assumption is that opioid analgesics, epidural analgesics, or anesthetics are indicated. For this theory to work, the patient has to have enough pain for heavy pain medications to be prescribed. The third assumption is that these medications are ordered and available to be used as needed for pain and possible side effects. The fourth assumption that the theorists make is that the patients are adults and they have the ability to learn, communicate symptoms, and set goals. This theory will not work for patients who are infants or people who cannot communicate their needs. The fifth assumption is that the nurses have current knowledge of pain management and can effectively use this knowledge. In acute pain, patient participation, multi-model interventions, and attentive care are needed for a balance between analgesia and side effects with decreased pain. The theory suggests that if nurses use a combination of multi-model care, which consists of medications and non-pharmacological therapies, along with attentive care and good patient participation, there will be pain management. Overall, this theory is useful in the clinical setting for alert adult patients in which acute pain is incompletely controlled by medications alone. I hope that after learning about this theory, you can use it in your own clinical practice.